So this will be again a small introduction only, because learning disorders in children is a very important topic. So again, a skeletal approach only I am giving, so that when somebody comes to us, we can guide them. So, okay, so we will go through some definitions, what is normal, deviations, examples. I am not giving the pictures that I have not collected now, and the approach. So what is this learning and memory? Memory is a general term for the mental process that allows the individuals to save information for recall at a later date. So we in a time scale, that is autobiographic memory, episodic memory, all those things are connected to the time and the event and recalled. So that is a memory. Recreation of patterns of the same spatial and temporal. So where it happened, when it happened. Produced by sense organs at a later date. So 10 years ago, what happened? You recall at a later date, and allows us to learn from the past, understand the present, and plan for future. So memory is evidence that brain becomes altered by experience. This remarkable property is the basis of thoughts, consciousness, language, and behavior. If there is no memory, there is no human beings. So human brain activates this using more than 100 trillion synapses, which evolved from the unicellular organism over 1 billion years. So learning is modification of behavior by experience. So everything we learn by previous experience, and then we accordingly change ourselves to suit the needs. So learning and memory is important for our social behavior. And memory is retention of that experience over time. So when we know somebody who was very hostile and there we get warned that we have to be very cautious, and somebody who is good to us, we get warned accordingly. So one of the major functions of learning and memory is to adapt to the environment. And it is reward and punishment based. What we mean by reward and what we mean by punishment is not physical punishment or physical reward. It is the nucleus accumbens producing pleasure signals and unpleasant signals. So that is what is the reward and punishment for the internal system. So still we really do not know how a person holds on to information so that he can access it in the same spatio-temporal template. We really do not know the exact mechanism. There are so many studies based on researches that has been done. And how stored knowledge is organized, like in a bookshelf. In a bookshelf, we arrange biology, mathematics, physics, chemistry, like that. Or in the library, you will find 1994, 2004, like that. So it is stored in that way, like a bookshelf. So that, like the way we pull out books and information from the library, we pull out these memory-based events. So it is postulated that brain stores information like a bookshelf. And Yendel and Tulving postulates long-term memory is of two distinct interacting systems. One is episodic memory of events, which helps us to go back in time with a presumed time marker. So this time it happened. And a semantic memory of facts or general knowledge. So these are the facts. So that factual memory, this is tomato or this is brinjal, that is factual memory. And this particular time, this thing happened, that is episodic memory. So how this I have very much simplified this information for our understanding. So we have level 1, 2, 3, and 4. This is polymodal association. How you remember cat looks like this. So it has got a cute look. It makes a sound and it is called cat and it is having a furry feel and it shows love to you if it is your cat. So all this information, polymodal information of an object is stored in the inferior parietal lobule along with this gestalt, that is color, contour, brightness, that is the gestalt. So gestalt clubbed with all this information becomes a holistic information storage. That is level 1. And consciousness is the basis of this cognition. So how this happens, you need consciousness. So how is the consciousness defined in our Upanishads? So that again, I always tell all this to make the younger generation understand what is the great culture to which we belong. So Kenopanishad says that which eyes cannot see, so eyes cannot see, consciousness, eyes cannot see, the ears cannot hear, the nose cannot smell, and the mind cannot think, but because of which the eyes see, ears hear, nose smells, and mind feels. This is Kenopanishad, and so many years back, when people investigatory tool was their own inner power, which is much stronger than any tools that we have. So that which eyes cannot see, ears cannot hear, nose cannot smell, mind cannot think, but because of which the eyes see, ears hear, nose smell, and mind feels. That is Kenopanishad. And that is the indestructible, the ineffable, the unmanifested, omnipresent, unthinkable, unchangeable, immutable, and eternal. And this consciousness is the one which makes the bookshelf. So it is into this consciousness that this bookshelf is made, year-wise, topic-wise, time-wise. No? And so these learning techniques, how do we do with our symbol? One is habituation. Second is associative learning. Third is complex learning. Habituation is you inhibit impulses. For example, certain information we need not store. They are triaged. So just for example, we see that we are wearing a dress. So nobody the skin need not keep on send information to the brain and distract it saying that you are wearing a dress. So that becomes habituation. When one stimuli is there, the dress is there, that is the stimuli, but it doesn't produce an action potential. But the moment the dress position changes, then it is facilitated. So when it is constantly there, when there is a stimulus, there is no action potential. That is habituation. So triaging information that need not be constantly attended to. And sensations to which a stimuli is harmful, enhancement. For example, if it is a fire or an insect, then even before the stimulus happens, just the nearness to the stimulus produces action potential. That is enhancement. So first is habituation of unimportant stimuli and enhancement of important stimuli. Next is associative, that is conditioning. You have got operant conditioning, and what normally we see whenever we have got food, salivation is coming. Food is having taste, smell, and other things, and salivation is for digestion. But by classical conditioning, whenever food is seen, saliva comes. I will be describing this a little more detail later. Then you can have operant condition. The operant condition is learned. For example, when the bell is rung, you know that a lunch interval is coming. So even without seeing the food, saliva comes. So that is learned conditioning. When the bell rings, it is lunch interval, food is going to come. So saliva can start even before the food is seen. Aversion learning is based on reward and punishment. What is all this I will be showing. Then complex learning is imprinting. Just you see your mother get up at 5 o'clock, you get up at 5 o'clock. You see your mother getting up at 9 o'clock, you learn to get up at 9 o'clock. And that is imprinting, seeing what is happening in your environment. That is why early environment is very, very important. Then latent learning. You really don't know that you are learning a technique of how to fit a electric switch. But you see your father doing, and so you have learned it. But when somebody is asking, we will tell that, I don't know how to do electrical work. But when an absolute necessity comes, you start doing, and you already know that. That is learning just by accident. And vicarious or observational learning Many things we learn by observation, even though we have not purposely learned those things. So these are different ways of putting information to the memory circuit. Then, so this is like we can see that when these are basic experiments, all of us, we know that Hebbian memory in the this snail. So when water is put, when the water is put, the gill will shrink. Normally, the gill is very opened up, and when a jet of water is put, the gill will shrink. But when you continuously put that jet of water, and the animal knows that it is not, when the snail knows that it is not harmful, it doesn't shrink again. That is called habituation. That's what I told by telling the example of dress. So filtering of unwanted information is an important part of memory. This is conditioning. See, normally you see food and then your saliva starts. Next, this is the Pavlovian conditioning. Then you see a neutral stimulus, the bell is rung. Whenever the bell is rung, you go out and you get your food. So the bell becomes connected to the food, even though it is not anywhere related to the food material. It is not a vegetable, it is not a fruit, but time locked to the bell. So when bell is given, food is given, saliva is coming. Later, even without food, you ring the bell, saliva will come. But if you ring the bell without connecting it to, for example, a child who has not gone to the school, you ring the bell, the child will not get saliva. But a child who goes to the school, digestive process starts. So this is learning by conditioning, conditioned stimuli. First one is example of habituation. Repeated harmless stimuli, you don't respond, so you don't consider it as a memory. Whereas this is conditioning meaningless stimuli into a pleasurable activity that becomes learned and fixed into long-term memory. And this is the aversion or punishment-based learning. So here, animal, this is it's called Skinner's box. Here the animal, when it touches a liver, food will come. And when it touches another liver, shock will come. So after doing it 2-3 times, the animal will learn. This is called aversion learning or punishment-based learning, reward and punishment-based learning. Then it knows that which one it should pull, so that it never gets the shock but only gets the food. So this is another basic principle of learning. So everything we learn by reward and punishment. That's why it's very important to appreciate good activities in children or adults. For even though I retired 5 years back, still I wish to be appreciated and feel happy. So that's a way of learning. So we'll press the lever for food only. So that is the mouse has learned from the Skinner's box that which lever it should. So that's a memory, basic units of memory. So what is the difference between classical conditioning and operant conditioning? So classical conditioning, a signal is placed before a reflex, like what we saw in the food or Pavlovian conditioning. And this experiment was developed from Russia, and it is known as Pavlovian conditioning. And it is also called respondent conditioning. And it works with involuntary behavior, because when food is there, saliva is needed. So it is not voluntary, it is their default mode in our system. And behavior is said to be elicited. You feel happy, you got your jalebi, you feel happy. And typified by Pavlov's dog. Whereas operant conditioning is what we saw in the Skinner's box. A reinforcing or punishing stimuli is given before a behavior. So when it touches, it gets a shock. And it is developed in the US, and it is known as Skinnerian, and also called instrumental conditioning. This is the way, it is one of the basic units which works in normal life and works with voluntary behavior. And behavior is said to be emitted and typified by the Skinner's box. And classical condition is involuntary and reflex. It is there. It is there in the default mode. Whereas operant condition is spontaneous, voluntary, and learned. And classical conditioning occurs before response. Whereas operant conditioning occurs after the response. And classical conditioning is passive. operant conditioning is active. Because the many things are not there in the default mode for us. When God created us, He created us to live in the wilderness. So many of the acquired memory processes are not there in the default mode. So they are learned by reward or punishment based operant conditioning. A neutral stimuli becomes a conditioned stimuli. That is, the bell becomes a conditioned stimuli through association with the unconditioned stimuli, that is the food and the salivation. Whereas operant condition, probability of making a response is altered by consequences that follow that, like the shock or the food. So this is basic. I have there is too much complex information about learning and memory. So I have just mentioned the basic units of learning in a child who was just born into this world and struggling to survive. So these learning disorders approximately affect 5% of all public school students. So they are very different types. It's very important. That's why I took up this small topic. I didn't know which topic to take. Finally, I chose this. Learning disorder is not a single disorder, but includes disabilities in many aspects related to reading, language, and mathematics. So what we understand by mental retardation, it's an irreversible brain disorder which slows down overall intellectual function. And it affects learning, communication, social interaction, independence, living, work, play, and sense of safety. So you do not learn the sense of safety, even though you have been bitten by a snake again and again. You don't learn like the Skinner's box learning. So those learnings are not taking place. And there is lack of curiosity. So you don't want to learn by being curious. You become curious and you learn new things. A mentally retarded person is no more curious, and therefore there is no learning. The IQ, if it is between 50 to 70, it is called mild. 35 to 50 is called moderate. 25 to 30 is called severe, and below 25 is profound mental retardation. That is categorization for rehabilitation purpose. So what degree of rehabilitation is possible for different kinds of children? So cruelty and kindness of history shows the irony of Hitler to the tears of the many for the ones affected. At one time, you know that abnormal children, Hitler had a physician who did an experiment on these children by putting them into fire, killing them and examining their brain. No? So their names have all been removed from the literature, even though their names were once attributed to severe degenerative disorders based on Hellward and Spots. For example, was his physician of Hitler, who identified many etiological causes in those days when imaging and all was not there, but by sheerly killing people with different disabilities, documenting and doing postmortem study of their brain. So that is the cruelty shown by some despots to these children. And currently we have many people, and also in the past, who showed a lot of tears for these special children. They are called special children because they cannot plan, they cannot kill, they cannot do any planned abuse or insult to their fellow human beings. So they are special children closer to God, and they are going to be liberated in this Janma only. So what is this history of love? Atharva Veda and Garbha Upanishad says childish mind is a gift. No? And Charaga and Patanjali classified it into different types. And Panchatantra stories, all of us know so many Panchatantra stories. Why these Panchatantra stories were made in those days? That was a training tool for special children. So Panchatantra stories were composed as a training tool to train retarded son of King Amara Shakti. So that training technique, which we boast as very new, was in that ancient times as Panchatantra story, which all of us know, and which was used to train mentally retarded sons of King Amara Shakti. And King Chandragupta and Ashoka made provisions for treatment those days. And in 19th century, Seguin and Madame Montessori started training centers in the West. but it started much earlier in our country, and people who lived much earlier have classified and categorized mental retardation. So I always feel proud to be an Indian. And a school in there was a first school started in Kurseong in West Bengal. And recent times, Mrinalini Sarabhai, who is the wife of the scientist, introduced dance training for these children to improve their socialization. And currently there is a magic planet in Kerala. Magic Planet is the world's first magic theme park. This was built in 2014, currently functioning under the extreme commitment of a person called Gobinath Muddukad, who is a magician, to protect public-oriented art forms and street performers. He makes people play this chenda and various other musical instruments which do not need fine tuning, but gross tuning. And many mentally retarded children are being rehabilitated here. They became very much obsessed with the chanda, so they don't need any antipsychotics. So now bringing happiness to so many specially able children. Currently, it is very much functioning as a great service work done by this Sri Muddukadan. Then sometimes we label children as regressive, even without regression. Somebody who was walking may stop walking, but it is not due to progressive extrapyramidal or pyramidal deficit. So we should remember this in children before we call them as progressive disorders. So progressive mentally retardation is a very bad disease. Static conditions are different. So if there is a contracture, a walking child might stop walking. So contracture only means that the child did not have enough care. So these are all pseudo-regression. And movement disorder, a child with spasticity, when the spasticity is improving, the abnormal movements will manifest. So it will apparently look like worsening, but it's not really worsening. Seizures can come anytime, and 3-4 seizures not treated, child will lose the skills. That is also pseudo-regression, not a progressive disorder. And systemic illness, a child with a static condition gets a severe pneumonia. After that, whatever occurred may be temporarily lost. That doesn't mean it's a degenerative disease. And development of hydrocephalus and side effects of drugs, malnutrition, emotional deprivation, all of us want. Even at this age, I want to be loved, I want to be appreciated. So when there is emotional deprivation, we become non-functional. That does not mean there is a progressive decline in the child's cognitive capacity. Supposing child is put in an orphanage, where they get food, stay, and a roof, but they don't get that emotional support. So the child will not gain anything. That does not mean it is a degenerative disease. So those things we should understand. Then we have got several categories. One by one we will see. The commonest is specific learning disability. So what is specific learning disability? Least understood and most debated disabling condition which affects children. So manifest with significant difficulties in reading, writing, spelling, or mathematics in the absence of any cognitive or sensory motor deficits and lack of adequate educational opportunities and instruction. So this leads to lack of education. So parents will tell he is very good in welcoming guests. He will distribute food and sweets. He will go to the shop and buy. But in the school, he is non-cooperative. So other faculties are all normal. So parents will tell he is purposely doing this. He can do all this. So that is specific learning disability. Only one parameter is abnormal. So mostly they are not understood. So they do not get their special training that they need. And therefore they lose their educational opportunity. So this has to be identified. So with special training, if only mathematics is lacking, that can be attended to. So that is specific learning disability. Other skills will be very good. So according to DSM-5, what is mental retardation? Persistence of difficulties in learning and using academic skills, inaccurate or slow, effortful reading, comprehension of reading material is poor, spelling, written expression, mastering number sense, facts, calculation, and mathematics and reasoning is poor. Affected skills substantially and quantifiably below that of expected age, and also interferes with academic or occupational performance or with activities of daily living. The problems begin during the school age years, because it is at that time that we start noticing all these things, but not fully evident until the academic demands exceed the skills of the child. And so they will say yearly he was normal, only now abnormal. In LKG he was first rank holder. So like that they will tell. So you don't write and read and all in LKG. You only narrate some rhymes. So then it will be first rank holder. So they are special skills which needs a test situation to be understood. It is not that it was not there. It was there, but there was no testing situation. And problems not accountable for other conditions. So this disability cannot be explained by some deformity in the hand or hearing or deafness or visual problem. The problem should not be due to intellectual disability, global developmental delay, hearing or vision disorders, and neurological or motor disorders, or due to psychosocial adversity, lack of proficiency in the language of academic instruction. Supposing a person's mother tongue is different and he is put in another language, and inadequate educational instructions, so the teaching instruction is not good. So it should not be due to any of that according to DSM-5. And specific learning disability means a disorder in one or more of the processes involved in understanding or in using language, spoken or written, that may manifest itself in an imperfect ability to listen, speak, read, write, spell, or to do mathematical calculation. The term does not apply to children who have learning problems that are primarily the result of visual, hearing or motor disability or gross mental retardation. It should not be there. That's why many parents will come and tell, madam, I think he is lazy because he invites guests, treats them well, cleans the house, help me in the kitchen, but in the school alone, he is wrong. So that is the clear case of specific learning disability. What is dyslexia, dysgraphia, and dyscalculia? Dyslexia is a core speech sound. You see, dyslexia, you have to read and convert it into a sound. So what you read in your book, you read loud by converting it into a sound. So dyslexia is a core speech sound deficit. So what you see, you are unable to convert it into a note. Notably, inability to translate letters and letter patterns into phonological forms, naming speed, and working memory. So what you are reading, you are unable to convert it into a phonological form. You are unable to convert into a sound. So we think the child is unable to read. It is really not they are unable to read. They are reading. But what they read, they are unable to convert it into a phonological loop. So they cannot read it loud. And also well-documented dysfunction of the reading network at the neural level. And cognitive deficit in processing speed. So there can be a speed processing defect. So they may be slow to read, slow to understand. And these are polygenic disorders. Then what is dysgraphia? Unexplained difficulty in learning to write. This is also not at all uncommon. They will say he will narrate all the rhymes, he will count 1 to 1,000, everything, but tell him to write, he will not write. That is dysgraphia. They are a specific disability only for writing. Dyscalculia. Disorder affects mathematical reasoning and calculation. So dyslexias, dysgraphias, dyscalculias, mathematical skills, they all come under one domain dysfunction. So how are you going to examine a child who comes with this complex complaint? So one is passive observation. You just allow the child to move around in our place. It all takes a lot of time. So the patients have to be understanding about our will and interest. There had been a situation in personal life when we spend so much time, when the parents are unable to give proper history, and after taking so much time, they make criticisms and comments. That's a very sad situation, especially in Kerala. So that is first step is passive observation. So you see the state of alertness, how alert the child is, how he is aware of the various things in the environment, how he attends to the environmental factors, what are his facial and limb movements, and is the limbs symmetrical or asymmetrical. So that is stage 1. You do it for few minutes and passively observe. Don't restrict the child. Stage 2 is examining him on the table. So by observation time, some rapport will be established. Then you can examine the child on the table, examine the tone, motor performance, using some instruments, primitive and postural reflexes. Then stage 3 is little more invasive, where child has to cooperate, like the fundus examination, cardiac examination, looking for organomegaly, other kinds of other system abnormalities. So that is stage 3. That will give us a clue regarding systemic causes presenting as learning disability. Then stage 4, so for example, fragile legs, things like that. So every system has to be storage disorders. Every system has to be examined to understand the real etiology. And stage 4 is child should be made to walk. So here child has to be proactively cooperative, made to walk, observe the gait for spastic diplegia, hemiplegia, waddling, foot drop, limping or ataxia. These are the 4 stages through which you examine a child with the above complaint. Then we have to do so many screening tests are there for developmental assessment. That is for documentation purpose, usually done by clinical psychologists, as it takes a lot of time to apply these tools. So we have got so many screening methods which are standardized. That is Danvers developmental screening test, for Pathak's Baroda screening test, Trivandrum developmental screening test, and you have got very many screening tests till the age of 2 years, and you have got other test for intelligence assessment, but intelligence assessment in early childhood has to be redone several times before we tell the final intelligence around the teenage. So there are so many tests that is for documentation of the degree of disability. Then developmental quotient must be calculated for each developmental milestone to find out the developmental delay, and it is it's a means to simply express a developmental delay. It is calculated as ratio of the developmental age to the chronological age. So the developmental age divided by chronological age into 100 is the developmental quotient. So serially we can see with the therapy or with drugs or whatever, what is happening to this developmental quotient. If the infant was born prematurely, the chronological age should be corrected for the gestational age at birth during the first year of life. And then it may be normal, it may be mild to moderate delay, or it may be severe delay. So then head circumference. Next is measure the head circumference. So there's a simple formula from birth. At birth, usually it is 33 to 34 centimeters. Then 2 monthly increment of 4, 3, 2, 1, 1, 1 till the age of 1 year. So in the first 2 months, it is 4 centimeter, and the next 2, it is 3 centimeter, next 2, it is 2 centimeters, then 1 centimeter, and by 1 year, it is about 46 centimeters from 34 centimeters, and gains 2 centimeter in the second year. So after this, it is per year. So initially, it is per month, then by per 2 months, and then it is per year 2 centimeters. And after that, after the third year, it is 1 centimeter in third year, and 1 centimeter till the age of 1 to 2 centimeters till the age of 8 years. Then Dine's formula is another formula for head circumference. Length of the baby, that is for smaller and bigger built children. Length of the child divided by 2 plus 9.5, which is a constant, plus or minus 2.5. So that is Dine's formula. So that is the proportion that can be applied to modify for the height of the child. Then problems to look for. What all problems we are going to look for when they are writing, so or reading? Reverse letter sequences. So when they have to write soiled, they may write solid. They have to write birth, they may write breath. So when they are having the material from the school, it is brought, you go through it and look for, very carefully look for, because our brain will complete. It will not soiled and it will read only soiled, but it may be solid. So carefully look for letter sequences, prefixes, suffixes, root words, and other reading and spelling strategies, and spell same word differently on the same page. So same word may be spelled differently in the same page, and they may avoid reading loud, and they may have an illegible handwriting and poor recall of facts and difficulty with comprehension, difficulty with making friends, and not understood body language and facial expression. You show anger, they don't realize and they come nearer. And trouble with non-literal language. Idioms, jokes, proverbs, slangs, they all convey meaning that they may not be able to understand, and has difficulty with planning and time management. So all these need careful looking, not by verbal questioning the parent. So trouble answering open-ended questions. No? You tell your what are you interested? So it's an open-ended question. Tell what you saw in your school. Instead of telling what is your teacher's name, it's a closed-ended question, one-word answer. Whereas open-ended questions have too many answers, so they are difficult for them, and they have poor memory skills. They work slowly, poor grasp of abstract concept, poor attention to details, or focuses too much on one detail. Or like autism children, only one. They may be focusing, it may be irrelevant only. Somebody is chewing some beetle leaves in the neighborhood, but somebody is taking a class. Instead of attending to the beetle class, they will listen to the sound of the beetle chewing. That kind of thing. Shifted attention, and may not complete assignments, inadequate vocabulary, and inadequate storage of knowledge. No? So these are the things we look for. We using the various scales is one. Then I told about the 4 stages of observation, table-based learning, examination, and child's cooperation. So during this, you record all these observations and categorize them. Look for subtle errors, and we have to document all that. And then we apart from the specific learning disability, which is one domain, we are now coming to the next category, that is attention deficit hyperactivity disorder. I told that by the habituation, we triage. By habituation, we saw the snail no more shrinks when water is pumped into that. This habituation is not there. So the child will attend to every stimuli in the environment. So you cannot fix on anything. You cannot fix on a class. Instead, the air moving, the door opening, somebody moving, everything you will attend to. So that is a failure of triaging. That is what I told in the habituation experiment, simple snail experiment. So attention deficit hyperactivity. You are not attending to one. So triaging is not there. So you try to attend to everything, not register, retain anything. That results in attention deficit hyperactivity. So this is a disorder of triaging, disorder of habituation, failure of habituation or failure of triaging, characterized by excessive activity, short attention span, and impaired inhibitory control. For example, when you are in a school, listening to your teacher's class, you are not supposed to look at the sound which is coming from outside, but you attend to the sound there, so you don't have attention and learning. So cognitive deficits in processing speed. So ADHD is a polygenic disorder characterized by failure of triaging or failure of habituation, resulting in hyperactivity, poor attention, poor storage, and slow processing speed. And it is one of the most common neurodevelopmental disorder of childhood. So we have got several types. One is predominantly inattentive. Only thing, poor attention. Attention span is poor. That is one type. Second is predominantly hyperactive. So the first type, attention is poor. The second type, they are hyperactive. So they are impulsive, destructive, rundown, and combination of poor attention and hyperactivity, both. So it can be purely inattention, it can be purely hyperactivity, or it can be combination of poor attention and hyperactivity. So first we saw specific learning disability. And we saw the basis of all this in a very, very brief way. Next is attention deficit hyperactivity. Now we are coming to the autism spectrum disorder. Finding it hard to understand what others are thinking. It is a social cognition disorder. So autism spectrum disorder is mainly a social cognition based disorder, unless ADHD, which is a triaging failure. So here, it is hard to understand what others are thinking or feeling. So the child is unable to think what the other person is trying to convey. So the domain affected is the theory of mind. They line up toys or other objects and gets upset when the order is changed. They repeat words or phrases over and over. They have echolalia. They play with the toys the same way every time. Same toys, same. They become obsessed with one toy only. Whereas the normal children will want to have more and more new toys. And it is focused on parts of objects. So child not only plays with the same toy, it may only play with a wheel and gets upset by minor changes and has obsessive interest. That is what only one part, only one toy, like that. So what is the diagnostic tool for autism spectrum disorder? You have got so many tools. Autism diagnostic interview. So it is based by interview, revised, and it is for children who are more than 2 mental age. And next you have got a diagnostic interview for social and communication disorders. So these are all paper and pencil based tests. And you have got autism diagnostic observational schedule. No MRI, nothing like that. These are paper pencil test questionnaire based and childhood autism rating scales, that is to rate the severity. So you here all this can be seen in the net. The number of questions are there and you score them and then decide probably it is a social cognition disorder. Clues: male gender more affected. Females can be, but it is less. Male gender more affected. Language delay is very unique. They gain language very late. They are self-absorbed mostly. Poor play with peers of the same age. Poor eye contact and poor social skills. So, and rotating around self. Gyratory movement. Arranging things in a line. Switching the light on and off. And hyperactivity and regression of the previously acquired language. So this is very important. It is not a static encephalopathy. Here what is previously acquired is lost and they have sensory abnormalities. What is sensory abnormality? Maybe hypoactive or hyperactive. For example, this sensory abnormality is when it may be hypersensitive to minor sensitive stimuli, hyposensitive. For example, as I told, when somebody is teaching something, the child may be focusing on somebody who is chewing upon, which we may not even hear that sound. They will become very focused, very obsessed with that, go to that person and hit that person. So that is hypersensitive to minor ignorable sensory stimuli. Or you call them, you speak to them, you shout at them, they are hypersensitive and unresponsive. They are sensory abnormalities in autism. Then other features are stereotyped or repetitive motor movements, use of objects or speech repeatedly, lining up toys, which I have told, echolalia, and using idiosyncratic faces, insistence on sameness. That sameness can be for a part of a person or a toy also. And inflexible adherence to routines, ritualized by verbal and non-verbal behavior, and extreme distress at small changes, do not socialize, rigid thinking patterns, poor greetings, and a need to take the same route or eat the same food every day. Highly restricted. They will, it's very difficult. It is true. Parents will tell, he will eat only idli. So like that. And highly restricted. Fixated interests that are abnormal in intensity or focus. And strong attachment or preoccupation with unusual objects. Excessively circumscribed or perseverative interest. Hyper or hyporeactivity to sensory input. That's what I told. You call them 100 times, they will not come. But a tobacco chewing sound of an old person in the corner of the room, they will become attracted, go to them and hit them or beat them. Unusual interest in sensory aspects of the environment. apparent indifference to pain, temperature, adverse response to specific sounds or textures, excessive smelling, like we say cooker sound, excessive smelling or touching objects, visual fascination with lights or movement. Then you have got grades. You have got 3 grades. One is when people are referring to high functioning autism, like Asperger's syndrome. High functioning autism also has poor social skill. They do not have eye contact. They are keeping to themselves, but they are high functioning in certain skills. For example, they may be musicians. They may be creative artists, but otherwise the social cognition is not there. That is, example is Asperger's syndrome. They are otherwise not socially okay, but in some areas they are wonderful. And second grade, where they need speech and skill training. Third is they cannot function on their need full-time carer. So they need a full-time carer. Third group. That's the worst type. The first type is they are to themselves, they are creative, they are very good, they can be achievers, but they don't have social cognition. Second group is no social cognition, in addition speech and no skills, like the Asperger's syndrome. So they are not high functioning. Third group is completely dependent. They need a full-time carer. These are the 3 grades. Then what is this Savant? Savant syndrome is a rare but extraordinary condition in which a person with serious mental disabilities, including autistic disability, have islands of genius. In my hand presentation, I showed some of my autism children who have written poems. So they have islands of genius, which stands in marked incongruity to their overall handicap. I have shown the videos of some of these children in my hand presentation. So next is dyslexia, primarily associated with the core speech sound deficit and with additional impairment in naming speed and working memory. So next group is, so we saw the specific learning disability, ADHD, autism spectrum, and dyslexia, dysgraphia, and then now we are coming to metabolic disorders. So metabolic disorders can present with varying degrees of cognitive cognitive deficits. So they are acute or chronic encephalopathy. So chronically they are dull, but during specific situations when the metabolic demand is coming, they become acutely deteriorated, resulting in various wrong diagnoses. You may diagnose as encephalitis, whereas it may be an aminoaciduria, which was quiet, but when following a febrile illness, you refeed them with the amino acids which cannot be processed. So the toxicity happens and they go into encephalopathy. So behavioral problems, and they have got muscle diseases, movement disorders. So metabolic diseases will have multiple domains affected. So they may have muscle, nerve, spine, liver, kidney, all those things. And there may be history of consanguinity in the family. Refeeding worsening. That's what, supposing you have got phenylketonuria. I have a large series published. These children, when they are having fever or something, they lose their weight. So the parents want to feed them with food materials which might contain high protein. So they are unable to break the protein because of the metabolic defect. So phenylketonuria becomes symptomatic when you overfeed them following a systemic illness. So the systemic illness is there, the child is recovering, family is feeding them with protein-rich diet, and they go into worsening. So you might think he had mild fever before, now he is comatose. So this is probably encephalitis. And you put antiviral agents, they do not respond. So this is classical refeeding worsening of metabolic disorders, and family history and multi-system involvement. Then we have to categorize these mental retarded conditions as leukodystrophies or poliodystrophies. Poliodystrophy is only gray matter. Leukodystrophy is white matter. Both will be having varying degree of combination, but predominantly what is it that is involved? So white matter diseases manifest little late, and they may have big heads, megalencephaly. Their seizures are rare, and if at all they occur later. Cognitive functions are initially normal, and they can have associated peripheral neuropathy. Spasticity is early and severe. Reflexes may be absent or exaggerated. Cerebellar signs can be prominent. Fundus will show optic atrophy. Evoked responses will be abnormal, and MRI will show hypo or dysmyelination. Whereas gray matter diseases manifest early, they usually have microcephaly, and the seizures are early and severe, and there is progressive cognitive decline, and they have neuropathy and all is not there. It might come very late in the course of the disease. Spasticity also comes very late. Reflexes are normal. Cerebellar signs are not there, and fundus will show retinal degeneration in gray matter disease, whereas white matter disease shows optic atrophy. Evoked potentials are normal, and imaging will show cortical atrophy. So these are metabolic disorders and white and gray matter disorders. So you have got specific learning disability, ADHD, autism spectrum. Then we have got dyslexia, dysgraphias. Then we have got metabolic disorders, white matter disorders, and gray matter disorders. Then these people will come for certification. What are the mechanisms available for that? So Department of Empowerment of Persons with Disability Bill was passed in 2018. Identification and assessment of the conditions according to the clinician discretion, where clinical psychologist and good professional association, this certification is done. Legally mandated guidelines on assessment and certification of all conditions, including specific learning disability, because they can be rehabilitated at their maximum potential by identifying their disability and training them accordingly. So how do you assess them? Intellectual disability assessed by the board of medical person, pediatrician, pediatric neurologist, psychiatrist, psychologist. Adaptive functioning by using the Vineland social maturity scale. Intelligence measured by the intelligence scales, and you have got so many of them. You use one which you become familiar with, and minimum age of assessment is 1 year, and at age 1 to 5 years diagnosis can be made. So till that time you have to wait to give the final diagnosis, and more than 5 years you can assess intellectual disability, and validity for different age group. 5 years, less than 5 years, the assessment is valid for 3 years or 5 years of age only. At the age of 5, you assess a child who is more than 5 years, it has to be reassessed at 10 years and 18 years. And what you do after 18 years is valid lifelong. So assessment learned after 18 years is only valid for lifelong. Then if the VS-MS score is 70 to 84, it is borderline MR, and disability is 25%. And if it is 55 to 69, it is mild, and the disability is 50%. 36 to 54 is 75% disability. And then 21 to 35 is severe, 90% disability, and 0 to 20 profound and 100% disability. So this is how certification is done. Next, what is the cerebral palsy? Cerebral palsy is a gross motor functional classification system. So it's a motor system disorder. You have got a classification system, manual ability classification system is there to identify that, and other disabilities are added to that. And we have got several grades. Level 1 is handling objects easily and successfully. The disability is 20%. Level 2 handles most objects but with somewhat reduced quality and speed. That is 30% disability. Level 3 handles difficulties there, need help from others. That is 40% disability. And they handle a limited selection of easily managed objects in adopted situations only. So specific situation only they can handle some objects, that is 55%. The cerebral palsy is purely motor disorder, and level 5 is does not handle objects at all, and it is 70% disability. So how do you screen for this? The teachers of class 3 or at 8 years of age. Till then it may be difficult. So we have to involve the teachers of class 3 or at 8 years, whichever is earlier. The screening committee headed by the principal, mandatory for both public and private schools, and teachers shall interview the parents to assess their involvement and motivation regarding the education of the child. And if the parents are motivated and the screening questionnaire suggests specific learning disability, then the child should receive specific training in that disability. And if that disability cannot be corrected, the child should be excluded from learning mathematics and other subjects he can do and achieve in life. So whatever is difficult, mathematics or one language, that can be excluded from his syllabus. The child shall be referred to pediatrician for assessment of all the etiological factors which you have undergone, including correctable metabolic disorders. And diagnosis involves a team approach involving pediatrician, clinician, rehabilitation psychologist, neurologist, and several steps of assessment is needed before we give the final conclusion. And as I told, the ultimate final conclusion happens by 18 years only. Till then, we may have hope that the disability can still be modified, and after the age of 18, what happens is going to be the permanent disability. And we have got various batteries which can be applied later to identify the permanent disabilities. And rehabilitation etiological approaches, supposing it is metabolic disease, you have got special diet, special metabolic management mechanisms, seizure management, spasticity management. So all those things are there. And ecological approach, that is naturalistic environment to nurture general improvement. So the child should grow in a place, not in a flat where two members are there. It should be a naturalistic environment with the trees, houses, people and animals. And there should be physical exercise, musical training. Then cognitive remediation based on the identified deficit. If it is remediable, we will remedy. If it is not remediable, exclude it from the syllabus of that child. And resources to practice on a specific task or ability. And interventions applied late may not be effective. So that is why by the age of 8 at least, we should identify the disability. What is EQ and what is IQ? Emotional and rational minds operate in tandem for the most part of our life. And emotions contribute to and informs the operational of the rational mind. And rational mind refines and sometimes vetoes the inputs of the emotion. When these partners interact well, both emotional intelligence and real intelligence are enhanced. You see, some people may be highly intelligent, but their emotional interaction may be poor. So even though they are highly intelligent, they do not socialize, they do not enjoy the positive or negative appreciations, so they do not become successful. Whereas some people may have only modest intelligence, but their emotional quotient is very high. So they become very high, easily motivated. So they mix and they are recognized, identified, and they are given prizes and awards because they know to project their achievements. So the both should be together for very successful life. And you have got emotional resilience, promotion, skills. So you can, as a child only, you can train them to promote their emotional relevance. So they become extrovert, project their skills and become successful. Risk-focused method, prevent research as premature, and prevention, how are you going to prevent? So it starts at the conception itself. Prevent premature birth, teenage pregnancy, and you have to provide proper health care. And once the child is born, and the mother and the child job training, and process-focused approach based on the specific requirement of the child and the environment in which the child is growing. Then a secure base, a sense of belonging and security. So unless we are appreciated, we become inferiority complex, introverts. So our skills become never recognized and we die unrecognized. So a sense of belonging, security. So we tell that children should be appreciated so that they understand that they have a value which they will try to project and become successful. And good self-esteem, an internal sense of worth and competence should be provided to the child in the environment. A sense of self-efficacy, a sense of mastery and control. Every small achievement should be appreciated and promoted. And at least one secure attachment relation, a mother, a father, grandmother, some reliable relationship is very essential for the child to grow. So even the orphanage provides food and shelter. That's the difference. So we belong to a huge country. So each one of us can think whether it is possible for us to adopt one child. So one Indian citizen will grow much better and be a person who can contribute. One orphan child will get a mother and a father. So that's the biggest contribution you can do to our country. And access to wider support such as an extended family and friends and positive community experiences, creating lasting connections. And specific teaching strategies and teaching material for specific disability. Whatever is the disability, identify disability-based training and individualized educational programs. And preferably, they should be in the regular school. And structured approach, phonological approach, decoding numbers, etc. when there is a dyslexia like disorder. Then audio, visual, both combined. Whichever skill is efficient in that child, the child will pick up. Then you can use a scribe when the child has got a hemiplegia, spasticity. Or if they cannot write, you can do oral examination, object type questions, shorter task, extra time, smaller groups, and sit with the teacher, one-to-one training. No? Simplified curriculum, dropping what is difficult, less number of languages, lower amount of mathematics, simplified task, self-care and social interaction training, comprehension, competency, and creativity of each child should be judged, appreciated, and promoted. And identify task and tools, introduce selected steps, function generation, and the child to expose to new tasks and new ideas. And parent-child interaction therapy is evidence-based, and it is very useful in children with ADHD. Then we have got the role of drugs. The drugs are used only after all these non-pharmacological methods are applied. No? Then you have to. Then you have got outcome with early detection. Okay, we have identified a genetic condition very early. These are the problems. So even though we have got so many therapies, so many skill training, ultimately are they becoming normal? That is not clear. So realistic expectation should be given. And you have got some patients can be made quiet by, as I told, Chandra and things like that. Even though so many methods, so many institutions are there, how much they get out of that? Do they become normal? Because some parents tell that I refuse to get a second child because I want to give the maximum training, so he becomes normal. They may never become normal. So that should be made very clear. And so many remediation programs are there. But how normal they will become, that guarantee is not there. And you can do genetic predispositions and prenatal plans for genetic disorders. You have got embryo transfer, adopting embryos of healthy parents when there is a genetic disorder, prevention of TARCH infection, looking after nutrition, substance abuse, control of infection, endocrine diseases, newborn screening to early identification, and immediate postnatal care. And even if a child is born with a genetic abnormality, epigenetic mechanisms, environmental mechanism can reduce this expression. So all those things are methods which are used, but ultimate outcome is not very good, but it can be good in some situations. Then how to improve memory according to Charaga, sadhana, rehearse. Moderate disability, you have to rehearse repeatedly. And you can do debate and discussion. So sadhana, vada, then paratandra avaloganam, continued learning. Tat Vidya Acharya Seva, humility and respect to teachers, and avoid tamas promoting food. So this is Charaga's recommendation. Rehearse, debate and discuss, continue learning, be humble, respect your teachers, promote sadhik food, and attention focused on difficult data, avoid cramming. You should not imagine the day before your examination you can learn everything. Organized, add emotions, rehearse, mnemonic devices all of us use, visualize concepts, relate information with each other, read loud and sleep well. So I only one child I put here because many children I put in previous sessions. The absolute answer in understanding cognitive neuroscience is we don't know, because it is a spiritual science, and we have to investigate with ineffective instruments focused on the world with our weak objects of perception. So nija vijaram, true understanding will come if we turn our instruments inwards towards achieving greater goals. So unselfish society, spiritual approach, complete humility, all these only will understand why these special children and why we, each one of us created differently, how we are going to, what I told is something about science. What it achieves ultimately may be not very satisfactory. So go beyond the eye and see the truth. We will see the diamond only if we turn our research into the right direction. Now we are like the washerman in the Upanishad who had a diamond and he used it to wash clothes because he did not know it is diamond. So the diamond is inside in our spiritual energy. These approaches certainly give a feeling of worth and engagement for short term for parents and children. There is occasions where hidden talents are identified and appreciated. Difficult behaviors are controlled with musical instruments. More than these children who are absolutely innocent deserve a living, loving world which cares for them and makes life secure. But ultimately, how much qualitative improvement comes to match with the rest of the society, we do not know. But we will try to keep this smile alive, making a world better place for special children, ordinary children, loving children, normal children to grow up with sattvic energy and make this world better and better places. More so in this war-ridden era, I thought this topic is worthy